We will discuss together in this short talk the endpoints of our treatments. So what we really want to obtain in our patients and how we target our therapy. I will not discuss, of course, the treatment of acute exacerbation of COPD because it's been treated in other sections as well as comorbidities or ACOS or other special situation like PH. So I will concentrate on the treatment, the targeted therapy of stable COPD. So my mentor, Professor Leonardo Fabri, he always taught me when I was a young fellow that we have to be crystalline in what we want to measure and how to measure. So I think most of the clinicians will agree with me that what you want to obtain in your patient is to have a symptomatic patient to get better and to modify the natural history of his patient, So particularly 2 points, I think they are critical. One is COPD exacerbations, and the other one, of course, mortality. And you can measure total mortality, mortality for respiratory and non-respiratory causes, but basically, if you decrease the mortality, you are sure that your targeted therapy will work. The second point is how we can measure something is clinically effective. This is a real important point, particularly for a disease where there is a huge variability of the symptoms in the time and sometimes also of the severity and the number of exacerbations. So there has been some tentative, particularly recently have been published on the Blue Journal, some numbers of what is a clinical minimum or minimal clinical important difference, like for FEV1, 140 mils, or TDI index, 1 point, St. George Respiratory Questionnaire, 4 points improvement. Exacerbation, there is a lack of absolute agreement in the community of respiratory physicians, but most people believe that a 20% decrease is something really important in 1 year. So we will review now the targeted therapy of COPD, stable COPD, according to its etiology. The vast majority of COPD patients are smokers, current or former smokers. If they are current, we have very strong evidence that when they quit, as they continue to quit in the long term, we can decrease their mortality. This evidence comes mostly from the lung health study, which is a study started more than 20 years ago and focused on COPD patients with very early disease, mean FEV1 around 80%, and they themselves have very few symptoms and don't consider themselves as ill. So you can see that after a follow-up of almost 15 years, there is almost a halving of the total mortality in this cohort of patients that are sustained quitters compared with continuing smokers. And when you dissecate the effect of quitting smoking on the different causes of death, you can see there is clearly an effect not only on the respiratory causes, like lung cancer, respiratory failure, but also on comorbidities. It's more controversial, but there are some data, if quitting smoking will decrease the number of hospital admissions. This is a large cohort from a Danish population study that show that, again, these patients are more severe, more advanced in their natural history, but again, if you quit smoking, you almost halve the number of hospital admissions related to COPD exacerbations. Are we effective? Well, not very well. Is a review, a summary table of the large mega trials of pharmacological treatment in COPD. When you look also at the most recent mega trials, you have still 1/3, more or less, of COPD patients that are current smokers during the inclusion criteria. This is because we have, yes, we have effective treatments, but again, when you look at the long-term percentage of continuing quitters using all the available pharmacotherapy, from the classic nicotine replacement therapy or bupropion or varenicline, still the results are very grim. Look in the last column at the difference between the placebo group and the active treatment group is more or less very small figures. And it's just 1 year of follow-up. Probably after 2-3 years, the numbers will decrease further. The second target of the etiology of COPD is represented by the small minority of COPD patients. We don't have clear figures, but some estimates are that less than 1% of COPD have a severe lack of a protective antiprotease named alpha-1 antitrypsin that have a decrease, a significant decrease below the protective threshold, and particularly these are the so-termed phenotype ZZ, double Z, particularly if they smoke, or maybe they have some other unknown or little known genetic susceptibilities, may develop a COPD. And we have now available on the market some replacement therapy, augmentation therapy for this protein, lacking protein. Unfortunately, the data from the clinical controlled trials are very, very small, and the evidence of the effectiveness of this therapy is weak. We are waiting with interest the publication of this large trial using an inhaled formulation of alpha-1 antitrypsin, because we expect to have more efficacy reaching the local side of the disease. And the results should be published soon. But for having a more definitive response, we have probably to wait longer term. You see, the expected publication of this trial is 2021. So I really think is an area which needs good data. The second point we can target in the therapy of stable COPD are the clinical features. As been presented many times during this meeting, the slide from the Gold Committee. And I think is a reasonable approach based mainly on the efficacy of currently available pharmacological therapies in the progressive decrease of exacerbation rate from placebo, basically SAMA and SABA pRNA. How work currently available drugs? Most of the pharmacological classes are considered bronchodilators, and they're targeting two major membrane receptors. One is the M3 muscarinic receptor, and they are antagonists of the inhaled antimuscarinics, or otherwise they target the beta-2 adrenoreceptor, and they are agonists, because in both cases, basically, you increase the cyclic AMP inside of the lower airway smooth muscle cells, and this will relax these cells, we deactivate these cells, and causes bronchodilation. Similar effects can be reached using PD4 inhibitors that block the degradation of the cyclic AMP in these cells, and high-dose theophylline. We are also using the class of best anti-inflammatory drugs, which work less better in COPD, because there is a positive synergy between beta-2 agonists and inhaled glucocorticoids in potentiating their effects. The inhaled bronchodilators, which we have available for the treatment of COPD, are basically divided according not only to the pharmacological mechanism of action, but also the duration of action and the start of their onset, of their action, but is less effective, as that's important, of course, for the treatment of stable COPD. According to the duration of the effect, we divided short-acting muscarinics, SAMA, long-acting muscarinics, and ultra-long-actings. They have 12 hours, the long-acting, 40 hours duration of effect, the ultra-long-acting. Similarly, for the beta-2 adrenoceptors agonist, we have SABA, LABA, ultra-LABA, just to introduce the short names. All the drug approved in the market for the treatment of stable COPD, they are effective bronchodilators. The effect is not lost during time. You see the same for antimuscarinics. But how to target our patients according to the clinical features? I think it's really reasonable to follow the recommendation, the gold recommendation for group A patients. They have few symptoms, very low risk of exacerbations, and we know that we are not able to modify significantly the natural history of the disease in this patient. But we are able, using this class, to improve the symptoms. So the use PRN of these drugs is reasonable. But when we look at the long-term effect, they don't change significantly the natural history of the disease. Neither the available pharmacological classes of drugs change the mortality, since these big trials, or the health status. When we have more symptoms, we have the chance to use a regular treatment with bronchodilators, long-acting or ultra-long-acting inhaled bronchodilators. They are more effective of short-acting bronchodilators in the prevention of COPD exacerbation and improving the symptoms of these patients. Which class is the favorite to use? LAMA, versus LABA, ultra-LAMA versus ultra-LABAs. There is one clinical trial that has clearly addressed this question. It's the POET trial, and has shown that ultra-LAMA tiotropium versus the LABA salmeterol twice daily, tiotropium significantly delays time to first exacerbation. Is enough? Don't know. Well, stages group actually C and D. Here it's more controversial what we need to use. Definitely, if we use a combination of inhaled corticosteroids and the ultra-LABA, here is shown the salmeterol fluticasone, but you can obtain the same with budesonide formoterol. You have a decrease of total exacerbation and mild to moderate COPD exacerbation compared with the single components, but not compared actually with bronchodilators alone, but not of severe exacerbation requiring hospital admission. We have now also available a new combination of ICS with ultra-LABA, and you obtain the same results. When you compare combination of ICS, LABA, or ultra-LABA against ultra-LAMA, who is more effective? Good question. We don't have a lot of data. Some data already published suggests that on the total number of exacerbation, the effect is more or less the same. There are some data on the health status that may favor the combination of ICS LABA. Also, we have now available, at least are approved in some countries, fixed dose combinations of ultra-LABA with ultra-LAMA. One is represented by indacaterol glycopyrronium, and the second one by vilanterol umeclidinium. We have evidence that these combinations are better than a combination of ICS-LABA? No. The only trial, to my knowledge, published so far was using as background in more than 70% of the patients ICS. So basically are comparing triple therapy with ICS plus indacaterol glycopyrronium versus double therapy with ICS, glycopyrronium, or tiotropium. Some of the data published here favor the double combination of two bronchodilators. It's very intuitive to think, okay, they act on two different pharmacological targets, they synergize together, but the evidence here is not a clear evidence on just patient steroid naive, is that the triple therapy may be more effective than double therapy on mild to moderate exacerbation. But again, despite the number is very low, on the hospital admissions, there is no significant difference. And also the differences are not very big on the health status. We need to wait, maybe next year, for the publication of this big, large trial, comparing for long term a combination of ICS-LABA versus the combination of ultra-LABA, ultra-LAMA. When we have C and D patients that are not controlled in their symptoms as exacerbation by the use of the current, of the previous treatment that I shown you, we have the option to add, particularly if they are very symptomatic with chronic bronchitis symptoms, PD4 inhibitors, roflumilast. But a big trial is still underway that probably will clarify better the indication. Is REACT trial, and is adding on the background of ICS, LABA, regular treatment, placebo or roflumilast. We can target also blood gases, not only ACE, B, C, D. It's very well accepted when you have severe chronic respiratory failure, long-term oxygen therapy, continuous long-term oxygen therapy will improve the survival of your patients and maybe also reduce the number of hospital admissions. More controversial is the fact of non-invasive nocturnal ventilation in these patients that have not only hypoxemia, but also hypercapnia. We can also target in vivo pathology. One of the talk of the afternoon has shown how CT scan can help you to understand how much we have of pulmonary emphysema in our COPD patients. And there is a small subset of COPD patients with FEV1 less than 50%, predominantly upper lobe emphysema, and low exercise capacity after an intensive program of pulmonary rehabilitation that have shown increased survival using lung volume reduction surgery. Another surgical options is represented by diffuse COPD patient with large bulla. So, what are the key messages and the perspective? Well, I'm sorry to show you that our clinical approach of target therapy of stable COPD is very little change in the last 10 years. Today, we are targeting smoking cessation, maybe alpha-1 antitrypsin replacement therapy, the ABCD, the long-term oxygen treatment, and other options. But these are the same option, maybe with different names, that we had in the past. So this is just an adjustment and improving quality of our drugs. The future, the next 5 years, shall we have something, a revolution? I don't expect so. I think we will use the same approach of today, and maybe we can get something of good from the pharmacogenomics, inflammometry, regenerative medicine, but are open questions. Thank you for your attention.
Thank you, Gaetano, for this excellent presentation that has driven us across the available treatments for COPD. And of course, there are many possible topics for discussion and comments. So there are some questions from the audience.
Gaetano, thank you very much, because you pinpointed the tools that we have available. I think that one of the issues that of the risks that we have, that we discuss a lot, and we don't use the knowledge that we have accumulated. And you actually focused on the targeted therapies that are available. You have been rather pessimistic on the last slide for the next 10 years. Five. I'd like you to expand because for the first time in your life that I know, you have been on time in delivering your lecture. So I'm astonished.
I've been menaced.
We have yeah, I know you have other 40 slides, but that's all right. I'd like you to expand a little bit your thoughts according to the philosophy of the meeting. Now, you obviously and appropriately focused on targeted therapy of COPD. But I think that everybody in the room now has heard and understand the importance of comorbidities. Now, and phenotyping. Now, do we have at least expert opinion agreement that a phenotype precisely identifiable, coronary artery disease, heart failure, and COPD, can be targeted by comprehensive approach that goes from smoking cessation to with the family of treatments that you have discussed and that we have available for whom we have evidence only on the single component. But do you think that putting together now, which is what you do, probably we do daily at the bedside, but not everybody does it. It is something that we could translate into practice today. That's my question to you.
Actually, is the best clinical practice we can do to have a comprehensive approach to our COPD patients, including the comorbidities. I didn't try because it was outside of the time allowed to install. Yeah. What I believe is really the importance of sitting people from different disciplines, caring for the different comorbidities, to create, like what is the approach of in the general practice, the approach in the hospital-based care to the patients, to have a clear guideline on the priority also on the treatment when you have a complex patient with multiple comorbidities. Because I completely agree with you that usually we treat, if you have ankle edema, you add diuretics. If you have coronary ischemic heart disease, you treat the disease. But again, we don't have a formal guideline to guide our decision.
Okay.
Can I add some?
Two short questions
Yes,
and short answers, please.
A very short word in your slide, because as usual, everybody forget the Cinderella, that is rehabilitation. And so you have to excuse.
No.
And
Thank you.
Yes.
Thank you.
And the
very short question.
But no, this is the point, because going after Leo, this is one of the therapeutical tools who are shared by cardiological and pulmonological patients.
No, I completely agree with you. I completely agree with you. I didn't forget. Simply, the title was targeted. So every COPD patient has to enter. Is the gold message.
Good answer.
Last question.
Professor Bonini.
Just a last comment. I think that we can agree on the fact that there will be no big changes, but this is not only a prevision. It's just enough to look at the analysis of EMA of innovation in the treatment. There are zero innovative products in this area, and if you look at clinicaltrials.gov or EUDRACT, you see that nothing is expected in 5 years. What could change the scene is the trend to have now open data. Because if you have access, this is ongoing, and it should be defined shortly. It is not clear how to access data of registration trial, who can access, and respecting the privacy of the patients and the rights of the company. But if we can access within 5 years to the data of all trials, there is the possibility to define phenotypes and therefore to have really a precision medicine for targeting patients. So I think that open data may change the scene very shortly.
I completely agree with you, Sergio. Actually, one of the big problem in the development of new drugs, and not only for COPD, for other diseases, is that most of the negative trials are not, still unpublished, and the data are often hidden and difficult to find.
Gaetano, I liked very much your connection between pharmacological and surgical tools, because I think that this double approach taught us that reducing lung hyperinflation is one of the most important targets for our patients, because lung hyperinflation is the major cause of symptoms and dyspnea and reduced exercise tolerance. So, because we here in Europe are not so much prone to surgery, I think that the best thing to do with your suggestion is to reduce lung hyperinflation by pharmacological tools. And in this way, by combining, as you said, different bronchodilators which act with different mechanisms of action, can really help us to implement a better life for our patients.
Well, Girolamo, I agree with you impartially. So, unfortunately, the time was too little to discuss in the details, for instance, all the
we can discuss
literature
outside
on exercise tolerance, because most of the review and the clinical trials in the area are very debatable. There is controversial, weak or moderate at the best evidence of an effect of bronchodilation on the health status and the
Okay.
exercise tolerance.
Thank you very much, Gaetano.